Hello and welcome everyone for tonight's EAO Just Ask. This is actually the last EAO Just Ask before summer break, so please enjoy our last Just Ask. Because this one, it's a real special one. We not only have one speakers, we have two speakers this time because the topic is so interesting and our speakers have so much to say. And with this, I first want to invite you again to our annual congress in Monaco. Please subscribe, go to Monaco. Yeah, also meet a lot of speakers from the Just Ask and definitely also from the Just Ask today in Monaco. It's from 18th to 20th of September this year. So go there and enjoy it. With this, I really want to enjoy the session tonight. And we have two great speakers. The first speaker is Professor Ana Castro. Ana is from Spain, but she actually went to Leuven and is the head of the perio department in Leuven. And she is a top-notch expert from a clinical perspective, but also from a scientific perspective when it comes to PRF. Ana, welcome to tonight's show on behalf of the EAO, and thanks for accepting to be part of this.
Thank you. Thank you very much for the invitation. I'm sure that we will all enjoy this evening.
Thank you. And for the second speaker, we actually go to Italy or we go to England. We really don't know. I mean, sometimes maybe she also doesn't know because she commutes a lot of times. Elena, we have Elena Calciolari. Initially from Italy, but also at Queen Mary Hospital, working together with Nico Stonos, also working in Italy, in Tuscany. Elena, you are a top-notch expert when it comes to the other biologics, when it comes to hyaluronic acid, when it comes to polynucleotide. And we thought, wouldn't this be a great opportunity to get you both together and to do a mixture of the best of all of these biologics. Elena, welcome also on behalf of the EAO, and thank you for making this possible.
Hi, Stefan. Hi, Anna. It's my pleasure to be here tonight, and I'm really looking forward for a nice discussion.
Thank you. We have a lot of people already logging in to hear your content, and we already have Pascal Valentini logging in. Pascal, hey. Thanks for logging in. Alberto from Spain, Lucrecia. A lot of people want to hear your content. And with this, I really want to hear what you have to say because I'm so keen to see the scientific stuff you've prepared and the clinical stuff you've prepared. We normally, as you know, it's a little bit the routine and the tradition of this Just Ask. We make it very interactive. So I maybe interrupt you. It's not unpolite, in particular with ladies. I would never be unpolite, but I would interrupt to ask a question maybe when it comes from the audience, or if I think I see something interesting or what could be discussed more in depth. So with this, Ana, we will start with you to talk about PRF and all these aspects which are important in your implant cases. So Ana, please share your content with us, and we are very, very much looking forward to your work.
Thank you very much for your kind introduction, and welcome you all to this Just Ask. I think it's also the first one combined with the EAO Junior Committee, Junior Academy. So welcome to you, everybody. Tonight, we will talk about a really trending topic, I think, is the use of biologicals in implant dentistry. And my presentation will be focused on the use of PRF, of L-PRF in this topic. So let's go. I think that all of us has encountered some time with this situation where we are drilling and we see that we have a dehiscence, a buccal dehiscence on the implant. Of course, then we have different protocols to go for, different standard protocol and gold standards. But I think that at this moment, we also have these biologicals that can help to boost the healing and to accelerate it. And these biologicals, I'm talking about the APCs, so autogenous platelet concentrates. And this is not something really new. So from the 70s, it has been already developed some fibrin glue at the beginning. In 1998 is when PRP was used for the first time in oral and maxillofacial surgery. 1 year later, Anita and co-workers also described the PRGF, as I think that Elena is going to talk more in detail about these APCs. And then from the 2000, we have the platelet-rich fibrin, the PRF, with the different modifications that we will see also in this evening. And in 2018, we have in our group developed the L-PRF bone block, so that we will see also later on. So you see the evolution of all the APCs along the time. But I would like to give you a very short overview at the beginning of different APCs that you can also understand the presentation of Elena later on. And we will start with PRP. PRP is platelet-rich plasma. It's made from the blood of the patient, of course, and is centrifuged with anticoagulants. You have to do different centrifugation protocols, and at the end, to obtain a PRP gel, you will need to add some coagulation factors. In the case of PRGF, it is the one that Elena will talk about later, you also centrifuge the blood with anticoagulants, and you will need to aspirate a special portion, a special fraction of the blood, leaving apart the white blood cells. And the product that I'm going to talk about this evening is PRF, which is platelet-rich fibrin. In this case, you centrifuge the blood without anticoagulants, and that's why at the end of the centrifugation, you will get a clot inside the tube that you can compress with a special box into a membrane. And during this compression, you will have some liquid being released. That is what we call the L-PRF exudate. With this, we can also make this special construct, what we call L-PRF bone block. This is very much used in bone augmentation procedures, as we will see later on. How we make this, we combine L-PRF membranes with a xenograft. When we mix everything, we also are mixing or are using a special product, which is the liquid fibrinogen. And this liquid is also made from the blood of the patient, which is just centrifuged for 3 minutes. We can aspirate it, and this liquid is very rich in fibrinogen. So in contact with the platelet and with the thrombin in this block will make that the construct will be formed, and you will have this texture of really a block.
Ana, can I have a quick question? When you are sort of mixing it, do you expect a biological effect, or is that merely the mechanical effect of making a sticky mass?
Actually, both. Mm-hmm. Because from one side, you will have the effect of the fibrin matrix, that its form, that is indeed a mechanical function, which is gluing the all components. But as we will see in the next slide, this liquid fibrinogen is also biologically active. Yeah. It contains also cells that are releasing growth factors. So you are also adding an extra support of cellular support to your graft.
Got it.
So you have these both functions. Okay, I'll continue.
Yeah.
So as I mentioned, L-PRF then is a matrix, a fibrin matrix containing platelets and leukocytes produced from a patient's blood samples. We have also two different parts. The red part is the face, where we have the most cells, and the body, the rest of the part, is where we have the fibrin. Looking to the block, at the surface, we have this mesh, this fibrin mesh, mixing all the components. And then if we look inside, as I said, you can see there how this fibrin is full of cells that are also releasing growth factors. Recently, we have also in collaboration with the University of Santiago de Compostela, we have also looked at how we can explain the beneficial effect of this. And it seems that we have different effects that are very important also in implant dentistry. And I think one of the most important are the fact that L-PRF and L-PRF block are releasing these growth factors up to 14 days, but also, and this is also very important, this exudate release by the compression and also the liquid fibrinogen can be also considered as bioactive agents because they are also releasing growth factors. So as I said, then you are also adding a bioactive agent in your construct. So when we integrate PRF into our implant cases, and I think the first indication, the first application is, of course, in bone augmentation procedures. So we can use this beautiful block for bone augmentation. And some years ago, in our group, we have already described as a proof of concept the use of the L-PRF bone block. This study actually won the Clinical Innovation Award in the EAO Congress, where we have treated 10 patients using this biomaterial. We made some comium CTs immediately post-op and after 9 months. As you can see here already, this maturation of the graft. And then we looked at the bone gain, that we had approximately between 4 and 5 millimeter bone gain, and is actually in accordance with what we can find already in literature using the same technique, but different biomaterials. Another thing very important is the amount of bone graft resorption, that we had a mean of 15%. And this is also in combination or in accordance with what it is already described in literature. Even it's smaller also than what we can expect, for example, for other iliac block bones, for example, that we can go until 80% resorption.
Ana, can I interrupt you for a second? Very, very nice work. Congratulations. Does it depend also on the sort of biomaterial? I can imagine like different biomaterials soaks different quantities of the blood concentrate. And the second question, you showed like Istvan Urban's work. Do I also need to add autologous bone when I add biologics?
I think the rationale behind using biologics is to add this bioactivity to your scaffold, to your graft. This is what you have with adding autogenous bone. So you don't really need to add also autogenous bone plus your biologicals. Mm-hmm. You can, but the rationale behind using biologicals is to add this bioactive agents that you have with autogenous bone.
Got it. Thanks.
So this year we could publish these 2 RCTs in our center, really comparing the use of L-PRF versus the gold standard, which is the combination between autogenous bone and DBBM, in horizontal bone augmentation with a collagen membrane or vertical bone augmentation with a titanium reinforced membrane. How was it? We have one patient. We had the study was split mouth design. So on one side, we used DBBM with autogenous bone following the Urban and co-workers protocol. And in the other side, we use L-PRF bone block according to Cortellini and co-workers. So here you see an example of the surgeries. In the part of L-PRF bone block, we also cover the membranes with an L-PRF membrane. So what about the results? For the horizontal bone augmentation study, we could not see any significant statistical differences between both groups at any time point, and the same was observed for the vertical bone augmentation. Is it important? It is, because when using autogenous bone, you need to open a second surgical site to go and harvest the autogenous bone. So in this, when using the L-PRF bone block, what you can do is you reduce the morbidity of the patient because you are not really opening a second surgical site.
Ana, can I bring Elena into play for a second? Elena, these are very nice results, in particular on bone. I know your expertise is more in PRGF, which was always believed to be more good for soft tissue and doesn't have so much to do with bone. Can you give us some comments? Could we also achieve this with PRGF, or would you rather think this is something which we rather see with L-PRF?
Well, thank you for the very good question, a very interesting question. You made a very good point, because if you look at the evidence, there is not that much evidence on bone regeneration. When you talk about PRGF, it's mainly about enhancement of soft tissue. So this is why also when you have like a challenging defect or a challenging regeneration, like the ones that Ana was showing, you would not use PRGF alone. You would always combine it again with a scaffold, with something that will improve also its physical properties, because the physical properties are not so great. And definitely, I must say that there is more evidence in terms of bone regeneration in relation to PRF. But I will show you what we got with PRGF as well later on.
Perfect, thanks. Ana, please.
Okay, so of course, sometimes you go for a bone block. And then the question is, can we use also L-PRF in those cases? So once you have placed your plate, you push, you fill the gap, and then is a moment to release the periosteum. And sometimes you have a very, very thin mucosa above your graft. So here L-PRF can also help you to cover the graft with these membranes. And it has been shown in literature that this might reduce the resorption of your graft, and it can also help to reduce the flap dehiscences after post-op, which is also very, I think, very important, this kind of treatments. How will you do that? So you do your bone augmentation like normally, then you start placing the membranes on top, as many as possible, with the face, with the red part looking at the membranes, because this is the most active part. And then what you can also do is with this liquid fibrinogen, you can rinse it to glue the membranes and to activate the whole region. A second application is also possible in ridge preservation. We have also recently published a systematic review and meta-analysis. And here we have seen how many RCTs the L-PRF has given a positive, a significant impact in the results, as you can see here in green. But we have also some studies where we cannot find any differences. But this here, we really need to be very careful and look at the material and methods. You don't have to open a flap when using L-PRF for ridge preservation. You need to use as many clots or as many membranes, preferably as possible. So it really needs to follow a protocol, not just put one of the membranes inside the socket and think that it will become bone. And we have spoken about the ridge preservation, about the bone augmentation, and now we will go to the sinus. It's also a topic that we love. And L-PRF can also be used in transcrestal sinus lift as a sole biomaterial, so not mixing with anything else, of course, always in combination with placing the implant. If we look at the literature here, we have survival rates ranging 91 to 97%. And the recommendation is to use 1 membrane per millimeter that you need to augment. So if you need to augment 4 millimeters, you use 4 membranes. For example, this is one of the patients that we included in the study of bone augmentation. We have, after 9 months, a very nice augmentation. We like to place the implants according to this pilot guide, but in the side of the 1/6, we don't have enough bone height. So then we have to lift the sinus. How we will do it? We place first an L-PRF membrane that will work as a cushion, and then we try to lift the sinus floor with osteotome, or you can use denser drills. The system is really doesn't matter. And then when it's lifted, then you are starting to introduce these membranes one by one inside the sinus. After a couple of, depending on how much do you want to augment, the sinus will be full, and then you can place the implant. In this case, we also cover the bone augmentation with an L-PRF membrane. Post-op, we can see very nicely how we have elevated the sinus floor. And after 3 years post-op, we have a very nice, stable marginal bone levels and a very nice sinus bone augmentation, sinus floor augmentation. Can we use L-PRF for lateral window? Of course. Here the same, we can use it as a solvent biomaterial, always in combination with an implant, because the implant will serve as a tent pole, will keep the membrane elevated, otherwise the sinus membrane will collapse. And it has been shown in literature that it has been suggested that you need to combine it with xenograph if you would like to maintain and to gain much more bone height. And this is actually what we have done here. This is an example. We would like to place an implant in the second quadrant, but we have only 3.4 millimeters in bone height. So we go for lateral window. We open the window, we elevate the membrane. In this case, we prepare also the osteotomy for implant placement. Before placing the implant, we place a little bit of the graft at the palatal side. We place the implant, and then here is very easy. This is really an application where the L-PRF bone block it's very handy, because you just pack it, put it in the sinus, and you don't have really a lot of particles around it under your flap. Pack it's very, it's easily, and then you can choose here. You can cover the window with a collagen membrane or with L-PRF membrane. And this is the post-op 3 years follow-up with a very nice result of the sinus. My last question is, can we go from here to here with L-PRF? This is not more soft tissue, of course. This is something that we also evaluated some years ago, where we have compared with an RCT the use of L-PRF versus the use of a free gingival graft when increasing the width of keratinized mucosa around implants. We could see really a significant increase in KT for both groups, but using a free gingival graft gave a 1.3 extra gain. However, if we look at the pain scores and at the between control and test, they were always higher for a free gingival graft, and also the time of the surgery was also higher. So if you need, I think it depends on the patient, and it depends on the situation, the clinical situation that you have. The gold standard remains the free gingival graft, but PRF can also provide you some extra benefits in soft tissue around the implants. So I gave you here some bites of different applications of L-PRF. I think it can be the initial step for a nice discussion. For me, it remains a question mark, the application of L-PRF in perimplantitis. We don't have much data at this moment, so I invite here all of you to do more research on that, and maybe in some years we can add this application for the L-PRF. And last but not least, I would like to invite you all to check on this website. Professor Mike Reina has developed this website, and you can find all step-by-steps of all applications, and also much more information about L-PRF. And with this, I would like to thank you for your attention. I'm really looking forward to your questions. But before, I think we have to listen to Elena.
Ana, That was amazing. Thank you very much. Great presentation. I mean, the people, they in the chat, they scream and say, amazing work, great cases. I mean, you have to look at it later. That was great, wonderful work. And I think it's pretty much one of the first randomized clinical trials show that there's a real great effect on bone with L-PRF. So congratulations to that. But Anna, the only thing which still remains unclear is what do you do if the patient is afraid to get blood drawn? No, that was a joke. So
that is a problem.
So you don't need to answer that. With this, we still have you here. The people are applauding you. We go to Elena, and Elena's work is amazing too. I mean, I know your work. It's great. It's a little bit in a different corner of biologics, which makes this evening so interesting for all of us. Elena, we can't wait to hear your presentation, please.
Thank you, Stefan. I hope you can see my screen now. And I would like also to congratulate Ana for a fantastic presentation. And I will skip some parts probably because she already spoke about the background. So as Ana mentioned, when we talk about biologics, and PRF is definitely an example of biologic, we talk about different types of, let's say, growth factors, monoclonal antibodies, immune modulators that we use with the aim to enhance regeneration, to have an enhanced reparative effect. So in other words, if we look at the, let's say, pillars of bone regeneration, so which are the, let's say, most important factors to have a successful bone regeneration, I would say that biologics has mainly to do with enhancing and boosting the cues and signals that promote bone regeneration. And if you look at the literature, there is a plethora of different biologics that have been documented for bone regeneration with more or less evidence, obviously. If we stick for a minute again to autologous platelet concentrates, obviously Ana is the super expert on PRF. I will not mention that, I will not touch that. But with our group in London, we have acquired some experience in the past years in relation to another platelet concentrate, which is part of the first generation. And if you look at this classification of 2009, it's an example of pure platelet-rich plasma. And this is plasma-rich in growth factors, PRGF. So what is the rationale behind using PRGF? So obviously, through the preparation protocol that I will show you in a second, you obtain a product that has 3 to 4 times higher concentration of platelets. Hence, you have an increased release of all those platelet-derived mediators like growth factors that trigger the healing cascade, as well as blood proteins like fibrin, fibronectin that act as cell adhesion molecules and regulate cell proliferation, chemotaxis, and again, obviously trying to boost the healing process. On top of that, we have some bacteriostatic and fungistatic properties, but one of the main differences as compared to L-PRF that Ana showed is the fact that here we do not have the leukocytes. Why is that? Because there are some studies that have reported that adding leukocytes increases, obviously, the secretion of pro-inflammatory cytokines by the leukocytes. And although both leukocytes and cytokines are obviously very important during the healing stages, during the initial healing stage, you may not necessarily want to add more leukocytes and cytokines during your healing. And so we were particularly interested in this sort of inflammation modulation property of PRGF. And this is why we started our experience with PRGF with a chronic inflammation, so with periodontitis, so treating periodontal defects. This is obviously off topic for today, but just to show you where we come from. And then from that, we moved to other applications more related to implantology, let's say. As you can see from this slide, PRGF has been tested, documented in all main types of regenerative procedures. So from alveolar ridge preservation to lateral and vertical augmentation up to sinus augmentation. Most of the times, I must say, in combination with grafts and barriers because of the limited physical properties of PRGF. And before showing you what is our personal experience so far with PRGF, I just wanted to spend literally few minutes to walk you through the workflow to produce PRGF. Because as Ana said in the beginning, the first generation products, they typically require the use of an anticoagulant first, and then you have to use an activator, which makes the process a little bit lengthy, right? And also we had some issues from a regulatory point of view in UK. Probably this doesn't apply to all countries, but in UK, when we went through the ethics committee, to get all our studies approved, they consider the use of the anticoagulant and activator as a manipulation of blood. So in other words, every study using PRGF was considered a CTEMP, which means a clinical trial of a medicinal product. And for any of you that has experience with research, you would understand that this is a headache, a huge headache, because it requires extra layers of monitoring, of regulations. So it was a little bit tricky. But luckily, now we have in the market a different kit that allows you to skip that part. So you no longer need to use the anticoagulant first and then the activator, which makes our life easier, to be honest with you. And you can see streamline the process here. So basically, you just extract the blood, then you centrifuge the blood, and then you obviously have to do this fractioning. So you discard the bottom part of your blood, which is the red cells and the buffy coat that contains the leukocytes, and you only keep everything that is on top, that is PRGF. And in particular, you fraction it in two parts, as you can see here. So you have the part that is closer to the bottom, the F2, the fraction 2, which is the one richest in growth factors, and we use it as a clot, as you can see probably in the video that is running on the background. F1, on the contrary, which is the one on the top, has a poor concentration of platelets and growth factors and is normally used as a sort of membrane. You can even use a nice plate and a weight to shape it in an even form as a proper membrane. And obviously, because we don't use the activator of the coagulation, the only tricky thing is that you need to wait for the blood to clot, right? And this varies between individuals, but on average, I would say that it takes 8 to 10 minutes. And after that, you have 20 minutes to use your F1 and F2. So this means that obviously you have to calibrate well your surgery. So you need to know when you're going to apply this product, because you have only 20 minutes. Otherwise, the clot will shrink and will release the growth factors. Anyway, so with our group, we were very interested in trying to better understand how this product works. And actually, I need to give the credit to Dr. Ahmed Naji, which is one of the PhD students that we have had at Queen Mary University. He did an amazing job as part of his PhD, because in his PhD, we tried to characterize the healing of the extraction socket. We use this model because, as you know, it's a very easy model to study. You can see the socket, you can do the extraction, you can monitor the healing throughout the time, even through imaging or through collection of the wound exudate. So it's a very easy model. And we treated the sockets, as I told you before, so with the fraction 2 as a clot inside the socket, and on top the F1, which represents the membrane, let's say. And here you can see a case. At 7 days, you see there is already a nice healing, very low or even no inflammation. And at 15 days, you basically have almost the soft tissue, the complete soft tissue healing. And obviously, we documented the whole workflow up to the implant rehabilitation and up to 12 months post-loading. The beauty of this model, as I said, is very easy to characterize. So what we did, actually what Ahmed did, was to take some intraoral scans at different time points. We also had a CT scan after the extraction and at 90 days, so before implant placement. And by overlapping all these images, what we understood is that PRGF, as I anticipated earlier, has mainly an effect on soft tissue. So it overall in the PRGF treated sites, we had this trend of reduced volume changes, but this had to do mainly with the benefit on the soft tissue rather than on the bone.
But Ana, can I ask you a question? I mean, why is that? I mean, isn't blood like blood? I mean, Ana draws blood, you draw blood. Why is there a difference on bone?
I mean, there may be different reasons. Obviously, when you talk about APCs, it's like an umbrella term, and there is everything underneath. I mean, all the protocols are different, centrifugation, everything is different, the composition is different, the release of growth factors is different. I think in general, if you look at the literature, the agreement is that the effect in general for APCs is more for soft tissues, obviously with some exceptions, but this doesn't mean that it cannot help also indirectly with the bone, because obviously if the soft tissue heals better, you have primary, wound closure. This allows, a whole better healing overall.
Got it.
Yeah, I think it's also a good point, because as I said, our suggestion is always put as many plots as you can, of as many members as you can. When we are using L-PRF, we are, for one extraction socket, we are inserting like 6 to 8 membranes inside. So it's not just one plot and that's it. So we are really adding a lot of cells, a lot of information there inside. So this might be a difference. I don't know.
Yeah, I mean, we also try to fill it in as much as possible, but that obviously depends how much blood you can draw from one patient, for another patient. So I think there are so many variables that sometimes it's difficult also to standardize a little bit.
But I think, Elena, your point is great. I mean, probably we get a quicker soft tissue closure. The quicker the soft tissue closes, the better the bone regeneration, which is clear. Okay, great.
And without going too much into details, but on top of that, we are now collecting some interesting data on how the temperature changes, because temperature somehow tells us something about inflammation, about the vascular changes. So if PRGF is influencing also the angiogenesis and the blood vessel formation. And also we are looking at the molecular aspect, meaning which are the proteins that are expressed in the wound while there is healing. And again, obviously, we confirm what we were suspecting, what we knew from the literature, actually, that we have a very nice modulation of the inflammation when we use the PRGF, and also an earlier cell division and an earlier expression of all those pathways that are related to tissue repair. But this is not the only biologic that we can use. So on top of that, I just wanted to discuss briefly about another possibility that we have. And I think we all agree that in the past years, hyaluronic acid has gained significant interest. The number of publications, if you type it in PubMed, has really increased a lot in the past few years. So why is that? Why we should think about using hyaluronic acid in relation to bone regeneration? Well, as you all know, hyaluronic acid is the main component of the extracellular matrix. So all cells have hyaluronic acid. So it has hydration function. It helps stabilizing the blood clot, initiating the angiogenesis, somehow modulating also the inflammation, and also accelerates fibroblast migration. So taking all of that together, obviously, you can hypothesize that this molecule can somehow help speeding up healing, right? And again, if you look at the literature, although there is, I must say, still limited evidence, it's coming, but it's still limited so far. The documented clinical applications spread in all types of regeneration procedures, from alveolar ridge preservation, lateral and vertical augmentation, sinus augmentation, and also there are some studies coming on perimplantitis defects treatment. And there are different types of products available. You can have hyaluronic acid alone or already combined with bovine bone. You have also the cross-linked one that is supposed to last longer and have a better stabilization effect on the blood clot. And you also have a combined product of hyaluronic acid and polynucleotides. And I just wanted to show you the experience of my group, both in London, but also in Parma, in Italy, about the use of this type of biologic factor. Just very briefly, why should we add polynucleotides? They are supposed to work synergistically with the hyaluronic acid because they give a trophic stimulus during the healing. They stimulate the fibroblasts, they increase the collagen production. And again, because we wanted to study how this works, we started with the post-extraction model, because as I told you in the beginning, this is a very straightforward model to study healing. So here you see a case of very traumatic extraction of a premolar that we treated according to the alveolar ridge preservation principle. So we used DBBM, the proteinized bovine bone mineral, combined with this gel containing polynucleotides and hyaluronic acid. And we covered everything with a matrix, a collagen matrix, also soaked into this gel. And to make a long story short, what we saw when we were ready to place the implant after 5 months is that the bone was really, at least the clinical feeling was that it was pretty advanced in terms of maturation. And, you know, this is not so obvious because sometimes when you use DBBM, although it's a very good material, you know that you can have the particles coming out and somehow it delays a little bit the healing process. So we decided to take a biopsy of the bone and to check the level of maturation. And actually, the biopsy confirmed that the graft particles were very nicely osseointegrated, and the maturation seemed already quite advanced, with most of the bone already being of a lamellar aspect. So taking that into account, we are now running this study in Parma that we just started. And in this study, what we want to do is basically to test whether adding this gel to DBBM improves bone regeneration, so that we have a similar maturation of the bone that we find in the spontaneous healing at 4 months, while at the same time preserving the volume maintenance properties of DBBM.
Elena, can I ask you a quick question? We also did some biopsies from bone augmentation, and we saw that combining it with hyaluronic acid, that there's more vital bone and less residual particles. Did you also see that effect with polynucleotides?
I mean, less residual particles, not necessarily, but I guess that depends on you know, how much you packed it, how much you mixed it. In this case, we now have reached this experience that we mix it in a ratio of 3 to 1. So 3, let's say, parts of DBBN and 1 of the gel. But no, we haven't seen that, to be honest with you.
Did you also have a control biopsy with it? Or you will have...
No, that was just, you know, a case.
Oh, I got it.
No.
Got it.
We are doing it now in this.
Okay, got it.
Yeah. So stay tuned. Hopefully we will have nice results soon. And obviously, taking this interesting and promising data into account, we decided to test this gel also in more challenging situations. Again, there is not much evidence in the literature. We are still at the level of case series, so take that into account. But this is a nice case where you can see we have a knife edge ridge, and it was treated with this combination of DBBM and hyaluronic acid with polynucleotides. Then we put a membrane, a collagen membrane on top that was nicely stabilized with the titanium pins. And again, at 5 months, you can appreciate that we had a pretty nicely regenerated bone with very nicely integrated DBBM particles.
Elena, can I get Ana into play a little bit now with that case beforehand? Go back one slide.
Yeah.
Ana, I mean, you showed pretty a similar case with your technique. I would love to hear your comment on that case. I mean, obviously you would do that with PRF, if obviously. Would you see a quite similar result? Or would you say like a PRF has more potential in that case? Of course, it's one case, but just to get your feeling.
I think that the idea behind it is quite rather the same, because you are using a scaffold, which is a DBBM, and you are adding a biological, which in this case is hyaluronic acid with polynucleotides. And in our case, we are using this L-PRF. And I see that the technique is quite the same. I think that you are using also the sausage technique, tacking also the membrane, stabilizing the membrane. So I don't see, it's difficult for me to say if one or the other is better, because we really need to start a randomized clinical trial on this. But I'm really looking forward to see the results of that study, because of course it opens a door by using other kind of biologicals in bone augmentation. So
okay, thanks.
I think it's nice to have options, right? Because not every patient is the same, and there might be the patient where the patient is keen to have the blood taken, and you can go for that, and another patient maybe is less keen, and you can have an alternative. So I think it's good to have options. right?
Great.
And so actually after the implant integrated after 3 months, when we had to handle the soft tissues, you see that we apically positioned the flap, and we used a matrix to avoid, another side to take a free gingival graft. And we also use, in this case, the gel on top of the matrix. Again, there is not evidence about that, but it's just as a booster to increase, let's say, cell migration and help also the patients in terms of discomfort. And here you see the final case. And I think I will go quickly on this one because it's more or less the same. You see as another case of lateral augmentation in a very challenging defect. This was a patient that lost a tooth due to a trauma. And in this case, you see we applied the gel on top of the defect directly, and then obviously mixed with the DBBM, and then again the membrane on top, nicely compacted and blocked with the pins and with a suture, and then we close for primary intention. And again, you see that at 5 months, we had a very nice amount of regenerated bone following this procedure, this protocol. And if I still have 1 minute, I will show you this other interesting case of another challenging situation. So you see, this is a case of an implant, a fractured implant. So we removed the implant using the piezo, trying to be less invasive as possible. But even if you are trying to be less invasive as possible, sometimes you get some particles of bone that come out as well. So this ended up in being a pretty large defect. And again, the defect was treated with the same technique that I just showed you. So combining the DBBM with this gel through the sausage technique. So again, packing the material and putting the membrane on top, stabilizing the membrane. And maybe I will move fast with the video. So here you see the pictures. And then again, you can appreciate the outcomes after 5 months. So you have basically the regeneration of what we can call it as a socket that was completely filled, but also we had a tiny amount of vertical augmentation as well, because obviously we had the peak that were maintained. So it was a relatively favorable defect. And so just to conclude, what can we say about biologics? Obviously, it's difficult to generalize because every biologic is different. But I would say that because it's an extra thing that you put, right? Because either you draw the blood or you have to buy an extra biologic, so it's a cost anyway, as you see it. So I think you need to decide to use it when really this adds something on top of your clinical practice. What that can be. So if, for instance, this allows you to treat with better predictability very challenging defects, or in situations where you know that you have a reduced regenerative potential of the site, like these large GBRs, non-contentative defects, or when you have a compromised wound healing potential because of the patient maybe. Again, there is no evidence about that, but rationally, if you think about it, if you have a patient, I don't know, with an underlying medical condition, so you know already that maybe the healing is not going to be ideal, why not using something to boost the healing? And also when you want to have, this obviously applies to all situations, but in all the situations where you really want to have a soft tissue closure for primary intention, when this is really crucial, like in aesthetic areas or when you do GBR. So in this case, using something that can help the soft tissue healing, I think is something that you want to use in your clinical practice. And on top of that, if you want to shorten the healing time frame, if this is advantageous because, for instance, the patient cannot wear the provisional for any reason. And on top of that, obviously, to try to reduce and mitigate patient discomfort. So in my view, I see this as the main applications or the main areas where I would think that I could consider using biologics. And with this, I thank you very much for your attention, and I'm really happy to welcome any question you may have.
Elena, that was beautiful. Thank you very much. Also showing us this beautiful picture from Italy. Of course, you don't show a picture from London. You show a picture from Italy. Understandable. That was amazing. I mean, both of your presentations were amazing. I am thrilled. I learned so much. The people in the chat, they applaud you. But I would like to get a little bit more of your knowledge. And there are some questions which I would like to hand over to you. I would maybe start with Ana. There's a very nice question from Orlando Alvarez. Orlando, hi, thanks for watching, and greetings to South America. Nelson Pinto has shown that the L-PRF alone in sinus lift procedures, so pretty much like the old technique doing sinus lift without any biomaterial. Is that something you would think of, or is that just something to look into the future, Ana?
No, this is something that we are doing for sure using the transcrestal approach. So, but always in combination with the placement of the implant. So we never, and actually we don't recommend only placing the L-PRF membranes in the sinus without a scaffold, so without a xenograft or a bone graft, or without the placement of the implant, because otherwise, as I said, you will get the collapse of the membrane, and at the end, you won't have the results that you want. And as I said, if you just put L-PRF, for example, without the placement of the implant, you will get some bone gain, but I'm pretty sure that is not what that will not be enough for afterwards placing your implant. So we do it, but always in combination with implant placement.
Ana, there's another question coming from Pascal Valentini, a little bit to the question of, does it help with perforations? So, I mean, could I use L-PRF to sort of cover my perforations in sinus lifting? Of course, you both don't have perforations in sinus lifting, but if you would.
Yeah, of course, absolutely. This is one of the main indications for L-PRF during sinus lift, and I love it. I think if you have had a perforation, because I think that all of us have had a perforation ever while doing a sinus lift, and you have this L-PRF, you will see how the membrane is really attached to the sinus floor, to the membrane. And it's very nice to see how then the membrane starts to move. So when you ask to the patient, like, breathe again, you see that there is a seal. The membrane is sealed, and the membrane starts to move again. So that's for sure an indication if you have any perforation of the membrane. Yeah.
There's one more question from Mario Romandini. Mario, hi. Thanks also for watching. To Elena. Elena, what do you think about like the patient-to-patient variation? Meaning, I think the question was a little bit, should we use that more in risk patients where we have maybe problems with wound infection or something? Or is that something we could maybe use as a standard?
Well, we're talking about platelet concentrate still. Obviously, I mean, there are studies that have tried to look at the composition of the blood in different types of patients, let's say men, women, related to the age, for instance, or if you have systemic conditions. And obviously, like for everything, for instance, aging is associated with less cell viability. So definitely there is room to think that there are different variables that can have an impact also on the quality of the product that you obtain and on different aspects like the release pattern of the growth factors. We don't know that much yet. I mean, we have studies that have documented the use, for instance, of these products, even in patients taking anticoagulants or antiaggregants, and it looks like they work. But I would expect definitely to have some heterogeneity in the response, like for everything, because there are so many variables to take into account. But I don't know if Ana agrees about that, but I think definitely there must be an influence of different aspects like medical history, age, as I said, the genetics even.
Of course, I completely agree, Elena. Indeed, it has been shown also, for example, it's a very small example, but that women have larger membranes. So you make blood from women, you have a larger membrane than for men. This has to do with the lower hematocrit that women has. So it has to do with different physiological variations inside the population. Elderly patients also have larger membranes. It has also to do with the lower, as you said, the lower cellular content of the blood. So I think that when we are working with biologicals, mainly working with APCs, with autogenous platelet concentrates, the case selection is very, very important. This is something that I think it's very important that we say it as a take-home message. Please select your cases very well. Any patient with indeed systemic conditions, with diabetes, with taking anticoagulants, it will have an influence on the mechanical structure of your membranes. So this is also very something that we need to take into account for sure.
Ladies, that was amazing. Yeah, one more point, Elena.
No, sorry, I just wanted to add that absolutely she's correct, but also at the same time, I would say that probably these are the people that need a boost. So if it's not APCs, we need to find a way to boost the healing in these compromised patients, right?
That was amazing. We still have many questions. I'm sorry for these questions which I couldn't address. We will manage that. Please put them in the chat. I think Elena and Ana will answer that, or you will see them in Monaco or at various conferences, come up to them. I only have one last question. It's always up to me to ask the last question. Elena, I see you using DBBM alone. I mean, of course you add a booster, but we have learned also from Dani Booser's work and Istvan's work that probably some autologous chips can always help with DBBM material. Was that a thing because of standardization, or do you also in your normal clinical work use DBBM alone?
Well, this is a good question. The thing is that you're right. I mean, there is evidence that, mixing it helps also with cell viability and all of that. But at the same time, if you think about the reason why you use the biologic is because you want to boost the healing and somehow reduce also, let's say, the pain from the patient from taking the bone from somewhere else. So what is the point in a way of, using this booster if anyway you're going to use the autologous bone, if you know what I mean? So I think the really good point of biologics is maybe that they can help you boosting the healing in those situations where really you can make a difference for the patient also in terms of discomfort. You can really avoid, let's say, more traditional techniques like taking the autologous bone.
Get your point. No, that's a very valid point. Try to limit the morbidity and probably get the boost from the biologics. Ladies, that was amazing. We're already off time, but it was so nice. The people applaud you in the chat. You can read that later. With this, I want to say thank you to all around the world, people from all around the world that logged in. They applaud you, they congratulate you. It was amazing. Ana and Elena, thank you very much. I learned so much. Please, everyone, come to Monaco. It's our annual Congress. Elena and Ana will definitely be there. If you have a question, to come up to them. With this, I want to say good night, good morning, good evening, wherever you are. Thanks again to Elena, to Ana. Thank you for making this possible. Also to the EAO. With this, enjoy your summer break. We don't have an Just Ask in August. We see each other in September at the Congress and at the next Just Ask. With this, good night, ciao, ciao, and see you soon. Ciao.
Ciao.
Bye-bye.